Brilliant. Thank you. So a warm welcome to everybody. Welcome, Mark, online. We've got other colleagues who will be joining us online once they get settled over in Stratford. We also have a number of guests with us today and people stepping in for colleagues. So welcome to Anna, who is observing us today at board and was with us at the end of our private board. Also a warm welcome to Gulsen, who's going to share her patient experience with us and dip alongside to support, and also Callum, thank you very much for that. We will be expecting Zena from the ICB to join us, so she might arrive any minute. She's probably travelling over, so she'll slip in at a time. We're also expecting Paul Mangtalo from the Guardian Service. Sue and Mike will be joining us remotely once they get settled. Max sitting in for Fiona, thank you very much. You're very welcome. I think I've covered everybody, and we also do not have any absences, so that's brilliant. Although, Mark, I know you will be dropping in and out as you need to attend to a few things, so we'll just look forward to when you pop back once we've seen you slip off. So thank you all for attending, and we're going to start off first of all with our service user patient experience from Gulsen. Nick, were you going to introduce and then we'll hand over so that Gulsen can share her experience. Thank you for coming.
Brilliant. Thank you, Chair. At every board meeting, we hear a patient story, and the purpose of the story is to enable us as a board to connect with patients and service users at a more emotional level. It's to help us understand the impact of their experience and to encourage us as a board to develop an open culture which is willing to learn and improve. So I'd like to invite Gulsen to talk about her experience.
Thank you.
Yes, hello. Thank you for inviting me for this meeting, and thank you for giving me the opportunity to share my experience with the service. My name is Gulsen Morris. I'm a patient. I'm dealing with quite complex medical issues. My diagnosis is short bowel syndrome, which started 11 years ago. 11 years ago, my bowels just twisted for no reason. I don't know. I say they probably partying inside me, that they partied a bit too much. They tangled and they couldn't untangle themselves. Anyway, and due to the twist, I had to have an urgent surgery. That was 11 years ago, and that is when my story started. After the surgery, everything was so sudden. I woke up with a stomachache, waking up from a life-saving emergency surgery. So everything was a bit overwhelming, too much to take on board. That was 11 years ago. What I would like to talk most about is my latest experience I had in this hospital, which was February last year, February 24, 2024. Having this condition for 11 years, I am aware that the condition comes with complications, and obstruction is one of the complications can occur. That I had that quite a lot of time. So I knew something was going on. Last January, 24 January, end of January, I knew something was going on. I knew my colostrum wasn't working properly. I was getting a bit pain and twisted funny feeling. I observed my feelings for about 2 days, and at the end, I said, no, this doesn't look good. It doesn't feel good, because my pain was getting worse. I wasn't able to tolerate any oral intake. I was throwing up. I was feeling nauseous. And at the end of, I think, 31st of January, I came to hospital in a minicab. I came to A&E, and I didn't wait a long time to see the first doctor. There was a doctor at the end of the waiting corridor on the corner. I didn't wait long to see the lady. She was quite, how can I say? When I was in the cubicle with her, she called the surgical team immediately. I suppose when they see my record on the computer, they can see I'm in and out of kind of hospital and patient. So she called the surgical team immediately and she explained I was holding a sick ball, like throwing up, I was bending down, I was in so much pain. So after 3 minutes in our room, then she asked me to wait in the waiting room. I waited there for about 2 hours, but what I want to raise here about this waiting A&E, waiting in the A&E corridor is I waited on the wrong waiting room for 2 hours, and I didn't know I was on the wrong place. I could see nurses were coming in and out of that big inside room, where they give the full treatment. And when one of the nurses came out, I said, I'm sorry, I said, I'm waiting here for 2 hours and I'm getting worse. And when am I going to see someone? Then she checked my name and she said, oh, you should have registered yourself on the other waiting area. Where is that other waiting? I don't know the other waiting area, So she kindly showed me. Then I was in a pain, holding a sick ball. I managed to get to the other waiting area, waited for the lady there was an administrator lady behind the window, waited for about half an hour there probably. And I told the lady that I was waiting on the wrong area and can they take that into account, and I'm feeling really worse. And she said, oh, everyone says that, but everyone says that. She kind of said that in a not believing me way. She said, everyone says that, I said, well, you can see my registered time. I was there for 2 hours. Anyway, while I was having this conversation with her there was other patients behind me. They were saying, yeah, this happened the same to us. So they were waiting in the wrong area when they shouldn't have. So this was last year in February. I don't know what is it like now, but maybe it's something to look into. So anyway, after I registered myself, then I was called into the first triage. I think it's called first triage. Then it was quick after that. A porter came, took me to the surgical, kind of like an observation room, assessment room. Then two young surgeons came next to me and they examined me. They asked me questions. Then Mr. Rain came and he examined me. And having this condition for 11 years, I knew I was going to get admitted. I knew something. I knew I could have a surgery. I knew all that, but I was hoping that I wouldn't. But anyway, Mr. Wayne said, you may need a surgery and we need to keep you in here for tonight just to observe you. And a porter came and porter took me to the surgical ward, Ocean Bay. And after arriving in Ocean Bay, I don't remember much what happened because I don't remember what happened too much, but I learned later on that I was in surgical ward, Ocean Bay, for about 2 days. I'm guessing I have a copy of my file at home, and when I check my records, on the second day I am on the surgical ward, there is a note that says patient was very, very shut down. Patient is very, very shut down, and the next note underneath is she's taken into the intensive care. So I'm guessing I had deteriorated while I was in surgical ward, and they took me to the intensive care. Now, when I see my records, I can understand how scary things could have been. Like if they, I don't know what I wish I could remember, but I don't remember. They are taking me to I'm not remembering they are taking me to the intensive care, or I don't, but seeing on my record, something must have happened really bad, so I needed intensive care. And I'm thinking, if they didn't keep an eye on me that close, or if they didn't observe me enough, I could have died, or I could have had something really gone wrong. So I am thankful for all the people who kept an eye on me on that day, on that time, and took to action to take me to the intensive care. And following day, I think, or maybe the next day, I had this surgery to untwist my bowels. And again, learning all this later, that something went wrong during my surgery. I don't know what exactly, but something went wrong with my breathing, I think. So they took me out of the surgery without finishing the surgery. They put me on ventilation machine, and I have that picture of that day from the time that I was on ventilation machine. Yeah, and I think I was on ventilation for 1 day. They observed me for 1 day, as far as I know, and they took me back to the theatre. Yeah, I don't remember all that obviously, but that's when I was in ventilation machine between the two surgeries. They took me to surgery, something went wrong. They took me out. They put me on ventilation machine. Then I'm guessing when things are improved, they took me back to the theatre and finished the surgery. So again, another wonderful people looking after me. I mean, I know that was a very, very serious, complex, life-saving surgery. Things had gone wrong terribly. I could have died. I could have lost more organ or further organ damage, but thankfully, touch wood, there's no further organ damage or organ loss, and they saved my life basically. Mr. Wayne and his team, the theatre team, and Mr. Mukherjee, my main surgeon, he is the surgeon who operated me many times. Mr. Mukherjee saved my life.
You make me sound like a serial killer.
Yeah. You took me out of a medical trouble. So, Mr. I think you were outside the country at the time, and someone contacted you. I saw all this on my records. That's why I know. So, Mr. Mukherjee kindly gave the story to the Mr. Wayne, I'm guessing, so they coordinated. I was recovering in intensive care. I remember those days a little bit, and suddenly there was a rush around. I was in my cubicle intensive care. There was a rush around me. Then I don't remember the rest again. What happened is my lungs collapsed when I was in the intensive care recovering from the surgery. And now I woke up with, there's another picture where I have a big mask on my face. Yeah, that one, yeah. I woke up with that thing on my face. It was such a big, huge mask. It was pulling my face side to side. It was heavy. So they were supporting me with cushions so my head wasn't, go one side, the other side. So that's a bit further down. So yeah, again, attention to detail, the quick action. Again, they saved my life. My lungs collapsed. It never happened before, but getting all that. So they put that big machine on and oxygen mask on me, and they kept me on that for about 2 days, I think, or maybe 3 days. When I was on that mask, there was a huge amount of air in the mask, obviously helping me to breathe. That air was making my mouth so dry, almost making me gag because that strong air, and I wasn't able to talk because they said you can't take this mask off. If you want to take it off, you need to be on the ventilation again. And I said, okay, I'll keep the mask. So, but my nurse, cleverly, she gave me a paper and a pen. She said, if you want to say something, I'll communicate, just write it down. That was good. I like that. So I wanted a break from the mask, just for a minute or 2 minutes so I could sip some water. I was feeling really dry. So I wrote on a paper, really dry mouth, and I had a break. So then the nurse called one of the doctors in intensive care. He said, all right, we are going to give you only 2 minutes break, but we are going to observe in that 2 minutes time. We don't want you to have a cardiac arrest. All right. Yeah, a bit risky, but I took the chance. So they took the mask off gradually, slowly, and there was one nurse watching the machine I'm connected to. She was constantly watching the machine. The other nurse was looking at me, like staring at me, and there was a HCA there as well. So there were 3 of them observing me non-stop. And 2 minutes gone quick for me, but it was enough, I suppose. They gave me some water, I drank some water. I wiped my face a little bit because I was getting all sweaty under the mask. So then the nurse who was watching the monitor, she said, no, we need to put you back to the mask now. She sounded like hurrying, she sounded like really firm command. And the other nurse gently put the mask on me and they connected me to the mask. I think I needed the mask on that moment right there. Otherwise, maybe something could have gone wrong. So again, another attention to details, another professionalism, but calm me. They didn't make me panic. They didn't make me worry. So that was another thing I remember from the intensive care days. And another thing is, I am on tube feeding. I have a feeding line on my chest for about 11 years again, due to my condition. I do my own connections and disconnections, the line care and everything. I do all that myself when I'm at home. But obviously, when I'm in intensive care, I needed the nurses to do that for me. And having experience from my past admissions that having some nurses, especially the ward nurses, not using the correct technique while they are dealing with my line, I was a bit worried, honestly, that I was hoping the nurses will deal with my line the way they should do it, using the ANCT technique. I'm learned that now. So I was a bit worried, but no, they were perfect. I was watching them quietly, lying down. I was watching them. Okay, they are using the gloves, the non-touch technique and all that. But I was happy with that as well. So my overall experience in intensive care was quite good. Well, I think I stayed in intensive care about a week. And after that, they took me back to the surgical ward. They said, okay, you're better now. You can go back to the normal ward. Okay, fine. When I was in intensive care, I was on morphine pump, obviously having a major surgery, but that I knew that was going to be stopped at a certain point. I knew that. But as soon as they stopped the morphine when I transferred to the surgical ward. Okay, fine, I understand. But they put me on tablet painkillers. And that they didn't work. Tablet painkillers didn't work for my pain. That is something I had to kind of raise an issue with every nurse who came to visit, every doctor who came to visit me, or sometimes nurses, a couple of times nurses came to visit me from the intensive care just to follow up. I told them that these painkillers are not working. I'm lying down and the table there to eat or drink. I was lying down and I wasn't able to reach out to my drink or my food because I was in so much pain. I had never experienced that much I used to call it monster pain in my life having this condition. I have suffered so much pain, but that pain was something else. I wasn't able to move. HCA used to come and say, we are going to give you a wash. I said, no, don't touch me. I'm in so much pain. Don't touch me, please. Because the tablets wasn't working. So one day, this took about 2 or 3 days. I think a few days later, a pain nurse came. I was in a side room. I was always in the side room. Pain nurse came and she said, how is the pain? I said, they're not working. I'm explaining all this now, but I wasn't even, if they asked me my name, I wasn't even able to say my name. I didn't have the strength to say my name. That's how much pain I was suffering. I said, I'm in so much pain. I need something. I said, I need IV painkillers. I tried to explain, look, I have short bowels already. Short bowels means it's not absorbing enough anyway. And I'm recovering from a major bowel surgery. How likely my bowels to take this and give my body to release the painkiller? How likely is that? She said, okay, I'll speak to the team and I'll come back. The next day, another pain nurse came. The first main pain nurse was in dark blue uniform but white lines, and the next day the one came in dark blue but red lines. I think they're a bit more senior, PhD nurses like that. So I explained to her all again, this pain is not going anywhere. I wasn't able to eat. Surgeons used to come and see me every day, and they used to say, are you eating? We want to know. You need to eat, and we want to know if everything is working. because during the surgery they had to cut my bowel to release the knot. They couldn't release the knot without cutting. So they cut the bowel and they released the knot and they connected them again. So they wanted to know if the connection is working, you know. So they kept telling me you should eat as much as you can, but I wasn't able to eat because I was in so much pain. My lunch used to come and go back same without touching. So I explained all this to the other second pain nurse, and she said she's going to let the team know. But no change. The next day, consultant lady came, pain consultant lady. After honestly long negotiation, I don't know why, but they finally put me on IV painkillers and short-term injections, immediate relief. And from then, I started recovering better because I was able to move a little bit. I was able to eat. I was able to have my HCHS give me my wash. I was going to have a endoscopy because I was having pain around my stomach. Surgery was lower abdomen, and they were wondering why she's got pain in her stomach. So they said, okay, we need to do endoscopy to see if something is going on in your stomach. And I declined this endoscopy because I said, I'm in so much pain, I can't have that done. They need to put me to sleep. If they really want to do that, they need to put me to sleep. My pain is unbearable. So I had to decline the procedure because I was in so much pain. If the pain team had given me the painkillers before, this wouldn't have happened. I don't know. I'm really curious why they were not changing my tablets to the IV tablets. Anyway, that's one of my experience. But I was a bit concerned. What else I can talk about? So much to talk about. But yeah. No. So, yes, my line care when I was in Ocean Bay with the ward nurses. I am on TPN daily. I need to have my TPN daily without any missing, if possible, if not possible. So when I was in Ocean Bay, I had to have TPN connected to me, obviously, but I wasn't able to do that myself. So that was another big concern because the nurses connecting TPN as if they're connecting an ordinary saline bag. No gloves or nothing, no, just a quick wipe, connect, and that's it. And I usually say, oh, can you please use the technique because it's a Figma line, you know. I was so unwell again with the pain. I was like, oh okay, whatever. I couldn't even manage to talk to them and warn them. But 3 days later, I started having temperature and having a line in a high temperature. They were worried that my line had infected. And one day, one of the surgeons came and he said, we may have to take your line out. And I was really angry because if they have to take my line out, and if my line is infected, that's because they're not using the correct technique. They're not using the proper technique. This is Sigmund line. It really needs a proper care. And I was really angry. And luckily, my line wasn't infected. My line didn't take any out, but I had infection on my wound. Then I raised a really big issue with the ward manager. I said, can I speak to the ward manager? I was really worried. I said, I can't take the chance of my line handled just like an ordinary line, you know, like cannula. So the ward manager took time to listen to me and she raised this issue. And the next day, nurse came to connect me with a glove, sterile gloves. I said, oh, good, at least they're going to use sterile gloves. But what happened is he put the gloves on. Then there was a blanket on me. He took the blanket so he can reach my line. That's another mistake, with the sterile gloves. He shouldn't touch anywhere else. It's not antiseptic anything. So then he put the line towards the me, and he said, "Well, I said you shouldn't really touch anywhere else with the sterile gloves." I said. He said, "Well, I'm not touching the your end of your line." I was so unwell, so weak, and so much in pain and fed up. I just left it. I left it, and I was hoping that I will be able to go home without having a line infection or losing my line. So that was my other concern. But I received a letter from the team. I think they're working on it, and that's probably improved or going to be improved. So that's good to know. That was another memory of mine and my worry. Oh, so I'm going back to the intensive care. So I'm jumping one place to other place. But when I was in intensive care, I was so unwell, and surgeon, I think surgeons or someone from the surgical team contacted to my next of kin, who is one of my friends, and they told her that I'm in a critical situation and basically I could die, and my family should be aware of it and they should come and see me just in case. And my friend, who is my next of kin, recently had moved to the other side of the London, West London. She traveled all the way to see me because I changed her now. She's someone else, my next of kin, because she had to come to hospital, sign the documents, and visit me. And I'm from Turkey. I'm Turkish, and my family lives in Turkey. I don't have any family, no relatives here. So for my family to come here, they need to get a visa. And visa process is a long process. So my friend asked the doctors if they can give some documents, something proves that I'm in a critical condition. That is why it's advised my family to come here. And she asked that, and about 10, 15 minutes later, the letter was handed to my friends. And she was very impressed with that because she was kind of running out of the time because she has a young family herself. She's working full time. She needs to go back home in West London. So she was hoping she would get the letter quick enough so she could pass the letter to my family, and then they can start the process. So that efficiency there was another good point of mine. Yeah.
Thank you.
All right. Thank you.
Awesome, thank you. And so hard to hear what a tough time you've been through, but really helpful that you share the good with the bad in terms of some fabulous care that you've really appreciated, and obviously anything that saves your life is going to feel like it was wonderful, but it sounds like there are areas where we've got learning as well, and that's why it's so helpful for you to come and share that with us, and I know that feedback will be looked into by the team, and make sure that we sharpen up on some of those practices that could really make a difference, so that people have that feeling of confidence all the way through their care, rather than those moments of anxiety that it sounds like you've experienced. But I'm really grateful to you for taking the time to come and share that experience with us. Yes, does anyone, we're a little bit tight on time, but does anyone have any particular questions or comments I wanted to share? Yes, Caroline.
Thank you very much for sharing your story. And clearly your reference of when what pain is over the past 11 years are probably very different to many people's. I think it would be wonderful when when you go in as a patient in ED, if there's any way that we can take some of these learnings. But because when you're completely calm and collected, no way round, it's one thing. If you're in absolute agony, you're confused. How does the signage work, and how So I think if there's any way that we can involve patients in doing some of those things, just some of the small practical things, walking around somewhere. So like you sort of almost like user testing from that point of view, because the effect of pain on your body, and also in terms of recovery, if there's any way that can be improved and the experience simplified, I think would be wonderful.
Yeah, that's really helpful. Thank you, Ruth.
Hopefully I'll help and try and wrap up a bit. The few things my name's Ruth. I'm a non-exec, associate non-exec, and I'm also a GP. So I know more clinical. So I understood again a lot more of your story. But I think the two things I really heard from your story is you are an expert patient. You are. No, you absolutely are.
You are.
Yeah, you completely are. And I very much heard it. And I think a part of a culture shift we need to have is to make sure our clinicians are hearing that.
Yeah.
So if we've got, and there's patients that are not expert patients, and they will have to rely on the clinicians more.
Yeah.
But actually for you, we probably had to rely on you a little bit more because you knew yourself
Yeah.
so incredibly well. I think the other thing I heard from you a lot was there's still parts of your time in hospital that you don't understand, and there's gaps.
Yeah.
And I think something as clinicians we forget sometimes what is bread and butter for us, or what was very normal for us,
Yeah.
was not normal for you. And debriefing people when they've gone through what they've gone through is so important, because for you to kind of almost close the door on that chapter, you need to understand everything that happened to you. And again, I think that's a bit of a culture shift that we need to do throughout people's stay, but certainly at discharge, to make sure that your questions have been answered, that you are aware of what's happened and what's going to happen next.
That's really helpful observation, Ruth. Thank you. Oh, Dip, yes.
Very quickly, there are things that Wilson did not tell you. And I know that she's happy for me to say this. Before all this happened, it's exactly 4 days, it'll be 11 years since I met Wilson and did the first operation in the morning. At that time, Wilson was working in the local government, and subsequently, that had a huge impact on her life. Her son was how many months old then?
When I had my first surgery,
Yeah.
8 months.
8 months. Yeah. And it was absolutely seismic. She went back to surgery, and she had at the same time her parents came from Turkey and they had a stroke.
Oh,
My mum had a stroke.
Yeah, and it was very difficult because they were not eligible for NHS treatment, aftercare, etc., etc. And one of the few happy things, I hesitated a lot whether to say yes or not. I'm sorry about that, Wilson. But one of the happy things I met was when initially Gulsen invited me, and I was not sure. Then her parents invited me to attend the first birthday of her son.
oh.
And me and her parents, I spoke in Bengali and they spoke in Turkish, and we perfectly understood. And I'm so grateful. That was one of the things that. Since then, Gulsen worked with us. But she is not just an activated patient. She actually joined the Department of Surgery and worked for us.
Oh.
And that's what I wanted to share. So, she really rebuilt her life. She has had this TPN for 11 years now. When we eat and drink, all of us do. She doesn't. She does for comfort, but not so much. So it's a huge thing to do. And what I've observed is something that we see in patients a lot: the massive resilience that we have inside us. It's very inspirational.
Yep, thank you for sharing that. And you're incredibly humble, Wilson. So thank you. You clearly have a huge resilience, and it's wonderful to hear what you coped with and how well you've done. Thank you. Marta, quickly, last one.
Yes, thank you, and huge thanks. And Ruth, I'm Marta Phillips. I'm also one of the non-executives on the board. And Ruth picked up very helpfully on the clinical side. I wanted to reflect on the organizational administration side of the issues that were raised. And I was wondering, as an organization, how we have responded, or how do we plan to respond to the organizational issues. For example, ensuring that patients who are asked to wait in the right place, and that their names are added to the right waiting list, so that even if they're in the wrong place, they can still be searched for and helped on their journey through the hospital. So it's probably something for our sort of operational side to pick up on and try to make sure that we improve in that area.
Yeah, no, I'm sure we will. Mac will take that
Yes,
and make sure that from an operational point of view, we share that learning. And if I don't know, I mean, changes may have been made since, because I'm sure you said you gave your feedback sooner, but we will certainly check that we are helping and supporting people to find their way around A&E, because it's, as you say, difficult when you're in pain and distressed and anxious. So we will certainly make sure that's picked up. Thank you. Wilson, thank you, and Dip and Callum, thank you very much for coming along and providing that support and added insight. Really appreciate it. Thank you. Yes.
I think there's an issue there about the interface between the urgent treatment centre and ourselves. Quite often where patients actually get lost is when they go from the urgent treatment centre to BHIUT. And I think that's an area that,
Yeah.
I mean, footprints on the floor and all sorts of things, but people do still get lost. And I think that's something that we
Yeah.
need to look at. There's not entirely there if someone is a problem with the urgent treatment centre.
Hi, Sina.
Hello.
Welcome. Obviously, racing against time. We're just about to move on to your item, but
Amazing.
do you need to settle? Can I get you a drink of water while you're
No, I'm all right.
Are you sure?
Yeah.
So, I think we have some slides for you, so we've got someone who can help you drive this. So, let me just welcome you. We have got a few people online. Mark, one of our non-execs, is with us remotely today because he's in and out of other meetings. And I think you've probably passed on route Mike and Sue, who've just gone over to UNEX, and you've come over here. So they've dialed in remotely from over there before they join the finance meeting. So I think everyone around the table probably knows you, but just for completeness, to introduce you, Zina, our chief exec from our ICB. And in a very timely fashion, given today's announcements, you're about to talk to us about neighbourhood working. So thank you very much for sparing the time, and I'll hand over to you. And if you're happy, we might ask a few questions when you get to the end of your presentation, if that's okay, and have a little bit of a conversation if we can.
Yes, thank you. And had I not got lost in reading the technical plan on the bus, I would have been here slowly.
It's obviously a right ripping read.
Well, I've been trying to understand whether or not it said anything different about neighbourhood working than what I'm about to say about neighbourhood working.
Excellent.
I thought you might spot that. So, hello everybody, I'm Zina, and I think I'm just going to talk to you in general terms, but I'm really happy to ask you to answer any questions, and then to come back to the board in future to have a more in-depth conversation, if and when that's helpful. So over the last, interestingly, the Prime Minister and the Chancellor and the Secretary of State launched the 10-year plan in North East London this morning. So they were at the Ludwig Guttmann Centre in Stratford. In fact, I think I passed Mark this morning on his way from there, because they were doing a bit of a visit to the dental school in the morning as well. And I think it's really interesting that it was launched in North East London. And in fact, there were a couple of different sites that we've been working with Number 10 over the last couple of days looking at for the launch, which kind of says something about actually where we are, certainly in parts of North East London, on this agenda already. Because we've got kind of sites that are already providing some of the services that are set out in the 10-year plan vision, which I think is interesting and probably helpful. So they chose to talk about the Ludwig Guttmann Centre as a kind of, as the sort of neighbourhood model, as showing the way, but equally they could have gone to St George's, actually, where we've, including BHIUT, worked really hard to provide integrated services based around a neighbourhood in a setting that also has the voluntary and community sector there, which kind of starts to feel like a kind of holistic community centre in a location that the community can relate to. So there's two slides. If you could do the first one, that would be great. And lots of you would have seen this slide before because we use it quite a lot. But we use it quite a lot because it is the descriptor of neighbourhood working that we've worked with people all the way across North East London to develop over the last few years. And the kind of individual components are all really helpful. So kind of the little houses icon is because actually neighbourhood health has to be based geographically. It's just kind of, a fairly fundamental part, isn't it? But it's also just making the point that this is about being for communities. You'll have heard the Prime Minister, Secretary of State and others talking about putting the patient at the heart of the future of the NHS, actually designing services that join up around people. We've talked about that a lot before in the NHS, but actually that neighbourhood health services vision needs to do that, coordinated and joined up, because we know that a feature of lots of patient stories that we hear all the time are that actually health healthcare isn't necessarily very coordinated and joined up. People that need to repeatedly tell their stories. A really important component of it, which from a very quick read of the 10-year plan doesn't come out very clearly there, but is really important to us, is this idea that actually we need to build on the strengths and assets of our communities, our local people, their families, rather than sort of start from a deficits model. And that kind of ethos really helpfully brings in social care and all sorts of other parts of the kind of voluntary and community sector, as well as a way of working with people. We have been talking all along about cultural prevention in all interactions, making every contact count. All of those other things really heavily emphasised in the 10-year plan this morning, using hyperlocal footprints and then targeting and seeking to reduce health inequalities. And then the icons on the other side, using our data to target resources that target our resources to those that most need them, and to enable prevention most effectively. The 10-year plan on neighbourhoods talks quite a lot about using genomics, but it talks a lot about using data, joining up kind of population health data at neighbourhood level, and that's very much built into our approach. Building on existing integration work, co-producing with communities, with families, with individuals, with patients is really important. And then finally, and it's really easy to say this, and then there's a whole world of work in actually doing it, recognising this is a culture change and needs new ways of working. My favourite current story about this to illustrate it is St George's, which is a brilliant facility in very, very many ways. I think you said this story before, was getting 5 deliveries of milk a day because there are lots of different teams there, so they'd all organise different deliveries of milk for tea and coffee and things, and actually a really integrated team would have one milk delivery, wouldn't they, because they'd be working as one team. So it just kind of illustrates actually the sort of people's natural gravity is to their team, their organisation, and you don't get integration just by sticking people in the same building. You have to do a huge amount of culture and integration work. So that's sort of broadly the Nell vision. We've made quite a lot of progress. As I said, we've got some places which look a bit like what the 10-year plan describes already. We've got some parts of North East London that have got a really strong, long history of working in neighbourhoods, particularly in City and Hackney. Also Tower Hamlets, where there's some really helpful learning that we can all draw from. We know that some parts of North East London have more assets to draw into this than others, and it's going to be harder to deliver and need to be delivered differently in some places than others. But we also know that some of the other things that we've been doing, like women's health hubs, provide a really good model to do that. And in fact, the Tower Hamlets Women's Health Hub features as one of the case studies in the 10-year plan. So we have done lots of work on this, as I said. Go to the next slide, please. We've worked with all of the places in North East London, so the sort of borough footprints, to develop what they think of their neighbourhoods. Now, this is not necessarily quite the final list, because I think actually when we started sharing this with people more broadly, they sort of looked at it and going, actually there's quite a range of different sizes. Perhaps some of those are a bit too big, perhaps some of them are a little bit too small, but it has been really important to us that we've co-produced this at place so that local authorities, voluntary sector, communities and others have sort of said, well, this is our idea of the neighbourhood. So these are the neighbourhoods that people have settled on so far. They're sort of still a little bit work in progress, and as I say, we do need to go a little bit back around the loop again. We've got 7 places. I can't remember which way the split is, whether it's 3 places where all of our PCNs are geographically aligned or 4 places. So it's about half and half, and we probably need to do some more work to sort of really align pieces, so primary care network boundaries and neighbourhood boundaries, because I think we can see from the direction of travel that probably it's not going to work to have a primary care network, which is got a completely different footprint to a neighbourhood. So there's a lot of enabling work going on in the background, including on population health and some other components, population health and data and some other components. One of the things that we have set out that we think we need over the next couple of years is an integrator function for each borough to really enable the shift to neighbourhood working as part of the changes in integrated care boards, as part of our reduction in size. There are set of functions that as strategic commissioner we won't have anymore. We'll need to transfer some of those functions into a function, an integrated function at place. And those are things like, for instance, pulling together and making sure that the winter plan, or the winter and summer plan sometimes, really works in that place. but also the support to primary care locally, making sure that the data is all pulled together, some of the work that we do with GPs and with community pharmacy on medicines and medicines optimisation. So those sorts of functions we'll need to put into an integrated function, but that integrated function in the way that we've set out and in the way that London has set out its case for change for neighbourhoods really is there to start pulling partners together to really see the implementation of the delivery of neighbourhood working. Those integrated functions are not necessarily for the long term, they're sort of probably a step along the way. The 10-year plan doesn't talk about integrators, it talks about multi-neighbourhood providers, or it's that set of words, it may be in a slightly different order, as being a sort of set of functions that can come together that can provide some of the things that I've just been talking about over time. And it talks particularly about primary care and GPs being real leaders of neighbourhood health delivery. So for North East London, we've agreed that we will set out these integrated functions. We will commission those. We'll work with places to identify who should provide that integrated function, which could be a partnership, could be a single organisation. And over the summer, I was meeting with the Chief Executive of the Acute Trust, the Mental Health and Community Trust, a lead GP and the Chief Executive of the local authority in each of our places, so broadly the leadership team in each place, to say, right, okay, so where are you thinking, what's your thinking about the integrated function locally? Who do you think would be best placed to provide it? Is there anybody who's well placed to provide it? If not, what work do we need to do to get there? What sort of or design work is going to be needed? What culture change is going to be needed to really help enable people to do that? Should I stop talking there, Sarah? I feel like I've talked quite a lot, quite fast.
You've covered a lot indeed, and really helpful to get that sort of overview and sense. And I'm sure there will be plenty of questions as to quite how we move forward with all of that in the most helpful way, because it's I haven't yet read the whole of the 10-year plan. I've seen just the summaries and so on, but it's interesting what you say. What caught my attention first there in relation to the integrator role. So there's a lot of interest in how we see that panning out, but the fact that, as you describe it, it's potentially a relatively short-term role. So I think what's quite interesting to understand is just how we see the landscape shaping up long-term. And I think what's being said about integrator in the widest sense is throwing up quite a bit of confusion now as to what's the future role of collaboratives, for example. Do they sit alongside and the integrators operate through collaboratives? Collaboratives, the longer-term shape of care provision, and integrator is a more of the kind of convener, get things going and get the intense focus on neighbourhoods. So I don't know how much you've given thought to that, or whether you've got any insight of how that's being discussed, that's regionally, nationally, to help us understand where that might take us, because it could be quite confusing.
Yes, and I too have not read all 168 pages of the plan yet. I did just try and skim it, but there's just too much there. But I did read the chapter on system architecture, now, albeit quickly, but I didn't see anything about collaboratives in that. Now, I may just have read it too fast, so we'll kind of reflect and look back. I think probably what happens to collaboratives is a slightly different question, I think, to what happens to neighbourhoods. So there are all sorts of reasons for health providers to collaborate together on back office services, on making sure, for instance, that clinical networks for particular specialties are working really well, to really think about what's the right configuration of clinical services, for instance, across a system. I think North East London is a coherent system. But delivering this, I find quite difficult to see how you would deliver integrated neighbourhood working through a collaborative, because a collaborative is sort of horizontal, and integrated neighbourhood working is absolutely necessarily to place sort of vertically integrated, including with local authorities and social. So I think we probably just need to work it through over the next few months.
Yes, and just the wording there, architecture. So there's a difference between the fixed organisational form, as opposed to the ways in which we work together in collaboration, which doesn't necessarily require change of organisational form, but is about how we work together, how we deliver, how we provide care in a joined up way, isn't it? Interesting. But I'll throw it over to questions. So Ruth, then Rabou, and Essie to start us off.
Hi, Zena, I'm Ruth. I am a GP. I'm also the primary care development lead for Havering. So I think part of my concern is we've got these huge cuts at the ICB, and yet the ask is therefore to stand up these neighbourhood working, which I think, certainly from the community in primary care, I think we've seen for a long time that this is a good way to go, but it's hard to see how we're going to have the capacity in our system to actually manage that, to do it justice and to make it successful. I think the other issue I have is around the infrastructure of, from a trust point of view. I can really see this working from bottom up primary care. I struggle at a trust level that when you have someone walking through your A&E and say in the North PCN in Havering, we've got a wonderful mental health programme that patient probably didn't need to be in A&E but could be signposted back, how we don't have the digital structure that identifies where these services are and how we can successfully signpost these people in the best possible way, and how our staff really are meant to know about all of these different services so they feel good on the ground. I think if that pathway is missed somehow, which it does get missed every single day, how we're going to work as a system to bring that back, and especially in a trust where we are so digitally immature and we're about to go through our EPR, this feels like 3 levels up from where we're about to enter. And it doesn't feel like the 10-year plan has taken into account that different areas are completely different stages of maturity.
Yeah, do you want me to go and come one by one?
Oh, yes, it's quite easier rather than carry it on your head.
So, yeah, I'm not sure I can. Sorry, not sure I can answer for the 10-year plan. I guess when I have heard it described over the last 24 hours, as I'm sure we all, it's described as a sort of rules-based but permissive system, allowing people to move at the speeds that they can move at. So I guess there's an implicit recognition that it's going to take longer in some places than others. And I completely agree. What way we want to get to is that this is all digitally enabled, so that when somebody turns up in your ED, actually whoever the clinician is that needs to look at their records can see that actually they either could be part of an integrated neighbourhood response, or they are already being supported by an integrated neighbourhood response. And we know that in integrated neighbourhood teams in other parts of the country, that kind of some of that is absolutely working. So there's a kind of, there's a model and a vision for how to get there, but the kind of actually doing so, as you point out, is really difficult. And I think in the meantime, we're going to have to work through, so what are the fixes that we can put in place? What are the workarounds? How much can we do by, relationships and actually being able to phone somebody in the North PCN and say, I have got Matthew Trainer in front of me, actually, kind of, can you provide some support for him in this case, and kind of, do the kind of warm hand holding rather than the digital.
Thank you.
Yeah, thanks. Thanks, Zena. Thank you for coming along and good to hear. So I was reflecting on what you said about the culture, the OD aspect of true partnership working. Having visited St George's Hub, recognise what you've said about co-location isn't really about co-working or co-production, but thinking from knowing your background and sat next to Leslie always influences me thinking, there's lessons learned, aren't there, over the last 25 years of neighbourhood working, single regeneration, etc., all that kind of stuff that we've done at a national scale but delivered locally. And there were 2 elements of that which I think is really important going forward for our patch. One is among that Ruth asked and you answered, in that each area is going to be unique and different. And the best way we're going to understand that is that co-production with communities. Before you came, we had an expert patient here talk about their experience, and it brings it alive that around boardrooms we haven't got the answers to what communities need and what their desires and ambitions are. on that. So I'd hope going forward that we have this real shared focus on working with communities on co-production outcomes, and that it's not seen as a medical or a health model, but as a sort of community and tackling inequalities, early prevention, intervention model going forward. But thank you for that, and it sounds really exciting. Start off a journey.
I think it is. I think it is really exciting. And your point about that co-production is why one of the icons in our vision is about building on assets and strengths, because actually there's a lot of stuff in communities already, a lot of assets already out there, and we sort of assume that we need to put a kind of health layer on top of it all, when actually some of the answer we know is actually accessing things that are already there.
That's a really good point. So I've got Leslie, then Andrew, then Marta, and we'll see how we're doing for time. Leslie.
So thank you, and a really interesting presentation. I suppose one of the things I hope we will do, given that we now have the 10-year plan, is that we'll take the approach of asking for forgiveness and not permission, because we've started doing a lot of thinking about this, and if we wait for someone to give us a roadmap to do any of these things, there'll be another 10-year plan given we've actually got a roadmap to doing it. So I think there's lots we could do, and we should just get on and do a lot of it now, assuming that it will fit in what they want at some point. Again, just having skimmed the 10-year plan, I think the references to social care looks slightly vague. Social care will be part of the teams, it says, but then talks about in the longer term there'll be changes when Louise Casey reports whenever. So I can see that there's going to be some challenges for us in some of the neighbourhood work, given that we know the stresses and strains financially that are on local authority colleagues. I think some of that is going to be difficult until the government any government bites the bullet of actually dealing with social care. I absolutely agree with you about an assets-based approach and a strengths-based approach, because that's really the way to go forward. We are, particularly our bit of North East London, is a bit of London which is quite poorly served for organised voluntary sector provision. Was always one of the beefs in Redbridge that if you looked at how London Borough's grants funding was distributed, about something to groups in Redbridge and probably even less in Torrance for Havering. So I think there's probably quite a bit of work that we have to do. There is a lot there, but it's a lot more informal in our part, North East London, which I think makes it much more difficult to access. So I think, again, that's a lot more work, and we would be relying in a small part on local authority colleagues to be signposting us in the right direction for some of that. And we were talking earlier this morning about thinking about, again, because of the part of London that we live in and the numbers of people that are in care homes, and we're thinking around neighbourhood working, and a lot of the driver for people coming to us, particularly through LAS, is care homes. I know there's some reference to that in the plan about care should go to them instead of them coming to us. But again, I think that's probably something that we need to think about in terms of how we think about neighbourhoods, that we don't just think about what you would normally think of as a neighbourhood, but we recognise in our neighbourhoods there will be a lot of care providers that we need to engage in what we're doing. Otherwise, we'll still get all of that happening because we've dealt with this bit of the neighbourhood but forgotten that bit of the neighbourhood.
Thanks.
And I think Leslie, that talks to why the neighbourhood needs to be properly hyperlocal, because otherwise you end up with a model that works for Tower Hamlets, but where there aren't very many care homes, but doesn't work here. And so kind of really engaging everybody and thinking about what is the right model, who needs to be around the table, and where do you start? You know, kind of which groups do you prioritise first is really important.
Andrew, and then Marta, and then we will have to move on.
Martha was me first. So
It was.
I just think there are pros and cons to this, but I think if it goes forward, a lot of clinical work is going to be done away from the centre. And I think we need to remember the important role of training and make sure that as activity moves away from the centre and away from and into general practice, but also into hubs and so forth, that we make sure there's capacity to train all types of staff. From a medical point of view, we need to make sure that we don't just have rooms for the consultant clinic, but we have room for the trainees to see patients. It's a great opportunity for training, but it also, if it's not done well, it will make training capacity even tougher than it is at the moment.
Yeah, it's a really important point,
Yeah.
which we probably just need to recognise slightly more clearly than we have done so far.
Marta.
What I find really interesting, and I was thinking about, is the comments you made around data. And I was thinking that potentially there's sort of two levels of data. One is, I'm assuming that organisations involved in delivering health outcomes will be reporting data to the ICB to enable it to actually see what's going on. But there's the other level of detail of data, which I think you've commented on and alluded to, about being patient-centred and clinicians or other health providers, when they're looking at an individual, have access to the right data. And I'm just wondering about the challenges around integrating that data, because there's data in the primary care area, there's data within the acute environment in our hospitals, and there's other data in other organisations that are providing healthcare. So is part of the planning strategy to actually draw that data together? Because I could see there's some real challenges that organisations have become used to in saying, well, we can't share our data because it's we don't want to full power of the information commissioner and all those other aspects of people being protective of their data, which will not help to solve the issue about having a patient-centered approach. I don't know if you've got any reflections on how that's going to work.
Yeah, it's really important, and it's why data is one of the really important enabling strands. London's quite a long way further ahead on this than quite a lot of other places, partly because it's had the East London and then London health and care record for a long time. So quite a lot of that, we already have the ability to put that data together from primary care, from secondary care, and from other places. At the moment, it's largely de-anonymised, but there are ways of the opposite of de-anonymising.
Anonymising.
Personalised, because you actually need individual
exactly
data
putting it, taking the anonymised layer off, so you can see it back as kind of individual patients. So there are ways that we can do that, and there's a very big programme across London on that data, and specifically looking at, so what are the first data sets that you really prioritise to enable integrated neighbourhood working to really happen. So we're kind of better set up than lots of the rest of the country to do the data. Now, there are still loads of barriers on kind of individual information sharing between different organisations. So a key enabler for all of this is going to be our information governance functions being really good and really networked and really working really well together. But I think it's perhaps not as much, the data side is, I think, perhaps not as much of a barrier as we might think it is. It's probably not as much of a barrier as
Thank you.
Zena, thank you. That's a really helpful start, actually, alongside our patient experience, just to sort of set up the rest of the meeting. And you are very welcome to stay with us as long as you wish, but we will also fully understand, given the pressures, that if you need to slip away, absolutely no problem either. So I think that gets us started. What we have just as a few sort of admin bits to do, I didn't double check if anyone has to declare any declarations of interest for anything on the agenda. Nope, jolly good. Okay. We then just had the meetings from our previous meeting, the minutes from the previous meeting, which was the 1st of May. Any comments or items to pick up? Okay. There weren't any matters arising, and I also don't think we have any current actions on the action tracker either. So let's move forward. We're going to move on to the finance section. I think we're going to start us off with the FIC meeting from May, and then Sue will look at that Tweedledum and Tweedledee on the screen. Start off with Mahboob, and then we'll keep Sue smiling so that she's jolly for her next meeting. And then we'll move on to Sue. Mahboob, first off with you.
Thank you, thanks, Chair. I'll be brief. Just need to mention 3 or 4, I guess, key things and hand over to Sue. So, at a very high level, what we're facing is between the projected end of this financial year. The best outcome we're looking at could be around 25 million, less than that, hopefully. There's a worst case outcome as well, and the worst case outcome we're thinking through of is that there could be loss of NHSE deficit support. There could be additional unplanned loss of income because of disruption due to EPR. There is the savings target as well, which for ourselves and most trusts, it's the highest ever in our history. So the variance at month 2, month 3 is significant between 25 million to 63 million. You could pick different figures to match that sentence. So that is the level of financial risk we are facing, and it's really important for the board. And I'm sure we understand it, but really important for that to be said in public. The impact that then has, particularly on savings, is on cash flow. Cash flow is low, was low at the end of the last financial year. It's low going into this financial year, and it's getting harder and harder as each month passes by, and we're off the target that we're meant to achieve for each month. And it's harder to get cash support as well. So Mike and the team are doing a brilliant job in balancing the payments that we have to make to providers, but it's something the board needs to be acutely aware of as a big risk for us. On the positives, there's some strong progress being made on agency and also on bank staff reductions. We've seen the delivery of what we've had in place embedded over the last few years and been really successful. Matthew mentioned earlier this morning, but we clearly are a very, very busy trust. June was our busiest month in ED. We've had the highest level of mental health attendances as well. So, puts a lot of emphasis on our service, a lot of pressure on our services, but a lot of emphasis on partnership working. And we just heard from Zena, we had a good debate around that. And that partnership with NELFT that Fiona is working on is going to be really important going forward this year. UEC and RTT performance amongst the best in London. And you often think, how do we manage such fantastic operational performance against a backdrop of an organisation that is significantly financially challenged, serving some very deprived communities? I think I want to say, from a point of my perspective, and colleagues who are on the Finance Performance Investment Committee, we've got some great staff here, but this is going to be a really, really difficult year for all our staff. So that's where I guess I want to just say as my intro, and I know we'll go further into more detail of these things later on. But I was on leave last week, and Sue always very helpfully steps in to chair the meetings. And so I hand over to Sue then.
Thank you. Thanks, Sue.
Thank you, Mahboob. I understand we're looming large. Can you hear us okay?
We can, yes, you've come alive. Thank you.
Thank you. So not a lot to add to what Mahboob has articulated. I think I would draw attention to the need to increase pace around the identification of areas where we can achieve the full savings target. And we were fortunate in the June meeting to be introduced to the new head of PMO, who has experience of working in this kind of space and who I'd got a strong sense would drive forward collating and pulling together stuff that's already happening and start to drive forward the pace on our programme of savings very robustly. So it was good to see that he'd joined the organisation. But we do have a big mountain to climb, as Mahbub has articulated, and cash remains a significant concern for us, particularly if we lose the deficit funding. The only other thing I would add, we made an ask at the last committee that we find some time to look at benefits realisation on the very many initiatives that we have implemented across the organisation as part of our streamlining, modernising and becoming more efficient, because I think it's really important that we learn the lessons of what worked and what didn't, so that we can continue to get better at what we do. But our fundamental underlying financial position remains as Mahbub articulated. Thank you.
Really helpful, thank you, and really good summary of what's been discussed at those two PIC meetings. Any comments from any other members, well, anyone of that matter, but anyone else who was at those meetings, any comments or questions on the PIC papers? Oh, good, thank you, really helpful. So that leads us in nicely to the financial position update. So let me hand over to you, Mike, thank you.
Hi everyone, thank you. Okay, so I mean, lots of the context has been provided. So we discussed at FIC that we're 3.2 million off plan after the first couple of months of the year. But actually what we've also got in addition to that is an external profiling difference in income, which means that, you know, we're reporting externally that we're 5 million off. That'll correct itself in September. And we're also working with the ICB to see whether if there's a short-term solution to that. So against our plan, we're 3.2 off, but there is an external view that we are 5 off at the moment. The drivers of that, as you can see, sit in the pay position for the trust. And as you look down at the financial improvement delivery slide, you can see that we've delivered we're 2.9 behind on what we should have delivered year to date, and that's largely, or half of that is within the medical and non-medical workforce, and then there's a gap, and this is the point Sue was just making. We've got 13 million of unidentified, which we are working to close down. In the last couple of weeks we are closing it down, but it's a lot of it's non-recurrent, so that will not help us as we go forward, but will help us this year. So there's a big drive on finding more schemes and making sure that everything is recorded that we are doing. The point that Mahbub was making around the range of risks, I think what we should say at the moment is that, you know, there is risk in the position that we are looking to manage down. So that 25 million reflects where we currently are with our savings programme, but obviously we're driving to close that gap and bring that gap down. However, the consequence of where we are at the moment is that we will be losing the Q2 deficit support funding, which is just short of £2 million a month for us as a trust. Now that is re-earnable. And if we can get back on track in Q2 and show that we've closed those planning gaps ahead of the second half of the year, there is an opportunity to earn some of that cash back. But if you then look at the cash slide, you can see that even if we deliver plan, cash is very, very tight this year. So if we deliver half of what we need to save, you know, we really are into that point where we are starting to have to consider management of payments. So that's really difficult, and the loss of deficit support funding will make that more difficult for us. So the only sustainable way is to reduce the amount that we spend. We know that income is essentially capped for us, so that is the sustainable way to have cash balances that are more comfortable. The only other point I'll make is on capital. So we have a largely committed capital programme for the year already. This is quite early in the year to be largely committed on this, but we are. So we just need to keep an eye on that and make sure that the choices we make, because we probably will have to make prioritised choices throughout the year, are based on need rather than kind of linear presentation of when things come along. So I think, as everyone said, this is a difficult context, but I think we know what the challenge ahead is, and we just need to get some more pace into it as we go through the year. Thank you.
Thank you, Mike. I suppose, I mean, reality in terms of the challenging context, as you say, a sense of trying to give us hope there in terms of the loss of deficit funding can be earned back. But I just wonder, realistically, how are we progressing with plans that might enable us to do that? It's a sizable ask to cut costs to the level we need to in a timely way to give us the opportunity to earn that back when you take into account also the challenges we're likely to face in terms of going through the EPR launch and rollout and so on. Is it something we are realistically seeking to pursue and have any hope of achieving, or is it more serious than that in terms of where we're likely to find ourselves in the over the next couple of quarters?
So, I mean, I think we have to be fully committed to try and close the gap, as I'm sure we are. I think it's going to be really difficult. So at the moment, I think, you know, as the work that's gone on in the last few weeks against the 13 million of unidentified, you know, I think we're probably into single figure territory on that now, just about. So we're closing the gap, but undoubtedly there is remaining risk. And, you know, I think there will be risk as we exit Q2 that we could be in a similar position. But I think we just have to try and take ownership of the run rate and do as best we can, recognising there's an EPR implementation planned, as well as, you know, ever increasing activity that we've talked about.
And bearing in mind always the quality and safety issues taking priority that sometimes constrain our ability to achieve the savings we might think are hanging there as worth pursuing, but compromised by quality and safety issues as we head towards them. Any other comments or questions for Mike? Thank you. I mean, it's a sobering position to be in. I don't think any of us under any illusions, but it's good to hear just how much effort is going into trying to make those savings, and to have got us to single figures, as you described, is huge progress in a short amount of time. And I know how much you and the team and everyone else for that matter is doing to try and drive that even closer to where we need to be. So thank you. Right. That brings us to Janine and the workforce people officer. Yes, workforce improvement programme.
So this so essentially this is the money challenge from a different angle.
Yes.
We have now you know, it's a real credit to all of the teams that we've now managed to get our agency spend to the lowest level that it's been in the last 7 years, in the context of an increasingly busy service, increasing demands for the teams. But what we're seeing is that whilst we have reduced our temporary spend, there's some core areas that we haven't been able to reduce down, and that's around the one-to-one specialling and mental health and around corridor care. We're continuing to, you know, through the partnerships and looking at innovative ways of tackling that. I know that we're looking at, for example, we're now going to be bringing in RMN support from NELP seconded into our organisation, for example. So we are seeking to tackle that, but that remains a very pressing challenge. Our workforce report does give some assurance, however, that even in light of us, you know, increasing the grip and control around temporary staffing, seeking to keep numbers as low as necessary to ensure patient safety, our staff still remain. They're coming into work, they're not calling in sick. We are continuing to make progress around employee relations and all of the other aspects of our people plan that we know will be necessary for us to be sustainable into the long term. I'll stop there.
Thank you. And it is really positive to see the positive shifts in terms of the recruitment position and the huge savings on agency and bank. That's a real credit to all the teams actually have worked really hard to achieve that. So thank you. Any comments or questions? Great, thank you. Right, and last item before we can let Sue and Mike go off to their finance meeting. So Sue, over to you on the audit and risk committee update. Thank you.
Thank you, Sarah. So the Audit and Risk Committee has met twice since the last board, but in reality, a lot of what we discussed has been superseded because we've subsequently improved our accounts at board. So the report is there. What I'm going to focus on largely is the external audit. And I want to pay credit to both our finance team and the external auditors for what was undoubtedly the smoothest audit process we have had for a number of years, resulting in an unqualified opinion. In the work that Mazars do for us, they do identify weaknesses in what they've seen, and they have provided us with a report detailing 5 significant weaknesses. We have requested from our finance colleagues an action plan on how these are going to be addressed, and we expect to receive that in August. One thing just to clear up some numbers. In the report, it tells you that our auditor said there was a possibility that our numbers would move by about 10 million. Because they were still working through some field work, and that was a possibility. We actually know between the last audit committee and the signing of the accounts that that number ended up being closer to 8 million, which is still a significant move, but was largely from items that crystallised in the last couple of days of the audit process, and therefore will undoubtedly feed into the action plan for how we can make improvements to our systems and our processes. But I have to say how pleased I am that it is an unqualified opinion that we have received, and we recognise and agree with the recommendations made, and we know that we will be pursuing them strongly through audit committee. There were a number of other annual reports and statements that were received, most of which have progressed to board. We also received the annual report from our internal auditors, which gave us strong opinion, significant assurance with minor improvement opportunities. So that's important assurance to the board around our controls environment. And then there were a few other details. We have brought on board our new internal auditors, and they have provided to us their proposed plan for the year, which had been approved through executive. Audit committee asked if there could be a little bit more of a focus on the work out the back of the Freedom to Speak Up process to make sure that we're acting promptly on concerns when they are raised. So that's been added into the audit programme on our request. I don't think I'll highlight anything else, Chair, but obviously happy to take any questions. But if they're about detailed numbers, I might have to defer to Mike for those. Thank you.
Thank you, Sue. And actually, I just want to reiterate my congratulations and thanks to Mike and the team. It's a huge step forward. And obviously, I joined the team just at the end of the last financial year, but there's clearly been a huge amount of work done over last year to get the last year's accounts ready to sign off actually into this financial year. So not only have we got an unqualified audit, but the fact that we've been able to submit and get signed off those accounts in the usual time frame is really impressive in terms of the amount of work that's taken. But what it also does is allows us to focus now on a forward-looking rather than correcting historic challenges position. And that's so important. As we've just heard from Mike, the financial situation is really challenging, so to know that everyone's efforts and all that resource can be applied in a forward-looking way is really encouraging and really positive. So thank you, and it's a really impressive amount of work, and obviously we can focus on those areas for improvement and those recommendations, but in a forward-looking way, which is really positive. So thank you. Anyone else got any comments or questions? Brilliant. Okay, I think we just need to cover off our trust seal use. We've had a couple of those. Let me hand over to Linda on those.
So received in audit committee and endorsed, and the seal's just been used twice on a building contract and a lease. So just for ratification. Please.
Excellent.
Thank you.
Thank you very much. So I think we can ratify those. Thank you. So Mike and Sue, thank you. I know you'll drop off when you need to. So thank you for joining us, and good luck with your next meeting as we carry on with ours. Brilliant. So I'm very mindful of time. Obviously, we are keen. We need to finish our public meeting at 4 o'clock today so we can join the national call given the 10-year plan. I'll keep my report brief, really, just to position a few things in terms of where we're at. I think just about everything I've attended over, certainly anything external over the last couple of months since we last met in public, have all been pointing towards, talking about and hinting at the 10-year plan. Many things somewhat constrained in terms of what people could say in huge detail because of that. Nevertheless, some really interesting events I've been able to attend. The King's Fund annual reception in particular, thanks to a kind invitation from one of our colleagues, was an excellent evening, and also really good to hear the King's Fund strategy, which was really exciting and impressive piece of work. Looking forward to seeing how that pans out. The national NHS Conferred National Conference up in Manchester was during June. Again, another huge amount of focus there on anticipating the 10-year plan, but some really good presentations, including from our own team. Had chance to listen to Matthew, which was excellent, and also Sophia in Janine's team, really good presentation on the partnership working that's going on, so that was excellent. I'm delighted that, and it's very timely and purely coincidental, but two of the visits I've done over the last couple of months have been, first of all, to the St George's Hub, which was amazing, and also to Barking, a diagnostic clinic, community diagnostic clinic, and a sexual health clinic. Just really impressive, actually, to see both of those units and get a sense of that community-based working. Real pride in the teams. Obvious at St George's, just I love the milk example, but the actual reality of how comfortable it is to have all those different disciplines in one building, and how much effort is going into supporting people coming in and making full use of all the facilities there, perhaps having combined appointments, being able to see colleagues in mental health teams as well as GPs and our own staff. And what was most impressive was just the number of volunteers involved in supporting people as they navigate that their appointments there. So that was really excellent. Similar, really warm welcome, and really enjoyed going to the CDC. Declined the very kind opportunity. I could have had an endoscopy while I was there just to try it out, but I decided I'd leave that for another day. But really interesting to see a camera of somebody, so somebody else's, so I let someone else on some of that. But in both of those, what was also apparent, apart from the fabulous work that's going on, there is clearly opportunity to make even greater use of the facilities we've got in both of those locations. So hearing the focus and the shift now in the 10-year plan to that neighbourhood working, it just feels like we are really well placed to embrace that and rather rapidly get onto it. Other parts of the country will have to wait for facilities to be created, premises to be opened or reallocated. We're sitting ready. And I think that's really encouraging and quite exciting. So really good to have a chance to see that. So I will leave it there for now, actually, because everything else has been just local visits, and for me, really fabulous meeting teams across our sites again, and really enjoying that. But I think those are the most important and relevant to the current context and what we're talking about today. And I'll let Matthew give your thoughts on where we're at.
Well, usually I go first, so I usually steal other people standing there, but this time Mike is taking quite a bit of mine. So I think in terms of today's report, there's plenty to read in there. I think the money is taking up a lot of leadership time at the minute, right across the organisation, because what we've tried not to do is to impose central targets and ask people to hit them. We've asked the clinical groups and services to identify savings opportunities locally. So there's people right across the organisation who've been looking at where we think we can reduce costs and where we think we can reduce waste, and also where we can try to address the staffing numbers that have been really driving the budget. And I think in Janine's report, you can see that actually our retention's in a really good place. Our sickness is in a good place, actually. And that, if you look at all those kind of key metrics of turnover, recruitment, etc., actually we've got the workforce in a relatively good place there. It's also interesting to note that we've got around 400 more qualified nurses and 140 more consultants. 90 more consultants, 140 more doctors than we did 2 years ago, actually. So, the additional investment we've made in the last few years has very much been in clinical staff. And what we're trying to do is really push down the use of agency, but also bank staff, in line with the additional investments that we've made over time. But that is taking up a considerable amount of time, always needing to balance off against the pressures that we're seeing on the services. And I think in that light, it's worth seeing that I know the NHS has always talked about winter demand. Summer's now as busy as winter. There's a slight change in case mix, really, but two of our two busiest months ever this year have been in the last couple of months, actually. And we're seeing, routinely now we're setting records for the number of people coming through the emergency department. That's reflected in our type 3 numbers. So that's walk-in patients who are seen through the urgent treatment centre, seen and treated by a GP or a primary care nursing centre, but also in type 1, which is the majors attendances, and that's reflected by an increasing number of ambulances coming in. And that does put pressure on our ability to drive down costs. And in the context of what's in the 10-year plan about neighbourhood care, what we're going to have to do is do some work with partners over the next few years to understand how many of those people who come into our hospitals can be successfully supported to access care elsewhere. We do know that we see people who've tried to get care in other settings and haven't managed to. I think what we really need to start doing, like what Zena said, is really working up what the pathways are that will make the biggest difference there and how we can help people, not stay away from hospital, but get access to the right treatment at an earlier stage when they need it as well. Folk will know from previous conversations here that patients with mental health needs and patients with mental health crisis are one of the sources of real pressure on the emergency department, and we're still seeing extremely high numbers of people coming in and seeking access to mental health care through the emergency department. We had a very, I think, thoughtful and considered piece done by Sky News, looking at the pressures on King George Hospital, which of our 2 sites is the one that tends to see most patients with severe and chronic mental ill health. And I think because of its proximity to the mental health inpatient units at Goodmayes. And I think it's rare these days for a news piece to spend so much time listening to the experience of patients and their families and their staff. I think as ever our staff, Emer and others at King George came across tremendously well in terms of what they're trying to do. But I think it was also really quite powerful to hear from the patients and families who are seeking to access care about the impact that the way the system currently delivers has on them as well. You can see in the report an average waiting time of 16 hours in A&E. There is some progress being made on that with the additional assessment capacity at Goodmayes, which is good, but the numbers are increasing all the time. So I think that's a good example of where we really need to think differently as a system about how we care for people. I won't say too much about waiting lists, cancer, radiology, I think Max will speak about that, other than to say it's good. And just to tee him up for that in the short period of time, it's good to see that we're making real progress on that. And the final thing is, a few of us have mentioned the electronic patient records. In addition to the money, either sorting out the money or the electronic patient record would be enough for 1 year, but we're doing both this year. And the electronic patient record rollout is really, really significant. It's at the heart of giving people access to the kind of connected data that we've been talking about here. It'll allow us to do more to understand the demand that's coming through our hospital, that will improve the safety of our prescribing, so we're not relying on interpreting people's handwriting. It'll mean that a patient who's seen in clinic one day and presents in A&E 2 days later, that we're not relying on finding the paper file to figure out what happened to them. So there's all kinds of benefits to it, but the rollout is a really complicated piece of work. We know it will reduce the amount of activity we can do in the autumn when it happens to us. So we'll do fewer operations, fewer outpatient appointments. Getting through A&E will be slower. Getting through the wards will be slower until we get the system up and running, because that's what's happened to every other trust that's done it. And we also know it will reduce our income for a period of time as well and affect our finances as well. So there is a really big organisational change coming our way in September that will have that effect on our services. We'll try to manage it in the safest and most effective way possible. But the same people that we're asking to drive the savings plans and keep the performance in shape at the minute are also getting the teams ready for electronic patient record. So by the time of our next board, we'll hopefully be in a position where we're about to go live with it. But there is a lot to be done between now and then, and we will go live when we think we can do so safely as well. So we'll keep board informed on that over the weeks and months ahead.
Yeah. Okay, thank you. Comments and questions. I've got Caroline and then Ron. And then Mahbub.
So this might be a question for Janine as well as Matthew. There was a push a while back around flexible working that you did, for all the many good reasons around flexible working. I wondered if that had helped deliver any of the savings, and whether you were considering any other things that you could push with it that could help to deliver savings on the staff
side. The campaign has had a positive impact in that we have seen a 41% increase in the number of flexible working requests that have been logged in PSR. I don't know if that correlates to a direct increase in actual flexible working, but it's just that I think recorded now. At this point, we're not able to make a direct link into savings, so flexible working equals X amount of savings. But what we are hearing anecdotally is that the teams that, for example, have moved to team-based rostering and so on, are able to figure out among themselves who's covering what shift and helping to reduce our reliance on temporary staff. So, and the further impact is also around. We know that flexible working helps with people wanting to stay and feeling valued, to have control of your day and of your work-life balance. And so that's positive in that sense. But in terms of being able to directly correlate to the financial impact, you can't do that.
Thank you. Ron.
Thank you. When you talked about the EPR, you talked about having a more joined up system. Have we sorted out the difference between our electronic patient record and the urgent treatment centre? Because they don't talk to each other at all, do they?
No, it's commissioned separately, Ron, and even once we're into it, we'll still have different systems in place in the urgent treatment centre and in the hospital. So we'll still have to figure out workarounds.
They still won't be joined up.
No, they won't be joined up.
Okay, thank you.
Thanks, Chair. Matthew's point, I just want to underline, is one about leadership capacity and capability, delivery of finance, as well as EPR. I mean, I think we should stop calling it EPR program because it is a digital transformation program. Whenever I saw it in emails, I used to think it used to really annoy me because it's not an EPR program in its own right. So all of that we've got to deliver this year. And Matthew, what's the feeling then amongst in the organisation, particularly the senior leadership, not just the ones around the board, but the centre of the organisation, because there's a lot of stuff we're putting on them. We've got high expectations, and what can the board do to help and support with this time?
Yeah, I mean, I think we're feeling pressure. I think it's fair to say. I think everyone's been conscious of the pressure. I think it's a shared sense of pressure though. I don't think there's any sense that, it's just Mike worrying about money or just Janine worrying about the workforce or Andrew and Nick worrying about quality. I think it's very much become a sense of shared responsibility. And I think we all have views on each other's portfolios. We're all quite willing to offer them as well, but in the right and constructive spirit, I think. And the real difference actually between where we are now as a trust 2 years ago is the strength and depth we've got in the leadership team that you don't necessarily see, but who we have within clinical groups at service manager level. Actually, some of the newer clinicians we've got rising through our ranks as well, with some real strength actually there. I think it's interesting. I mean, I was looking at our performance figures. Our all type A&E performance in May was 79.2%. Our type 1, which is majors, was 56.3%. 2 years ago, our all type performance was 58.8%. So just our majors performance isn't, 2 years now is almost as good as everyone who's come into the hospital 2 years ago. And in NHS performance terms, that's a massive, massive leap forward actually. That we've managed to achieve. There is much greater strength and depth in the organisation now, so it feels like the burden on the exec team is very much shared by the senior leadership within the organisation. And the confidence I have around our ability to deliver some of this largely derives from the strength of the broader organisational leadership in operations, clinical and everywhere else. I think from the board's perspective, we are a unitary board, but there's also that important role of evidence-based challenge. And I think, we've had conversations around with things like the digital transformation programme, how you move just beyond being reassured that things are right to really checking. And I think as we get into some tricky territory around the money and possibly around the implementation of digital work, I think it's just important that we feel able to challenge each other and that we do keep bringing difficult stuff forward. I don't think we're a board that shies away from having discussions about the tough stuff, and I think it's important that we keep that going. Partly because in programmes like these, if things do go wrong, you need to be able to scrutinise yourself and understand if you did the right thing at the right time. I don't think there's any. I would much rather we had hard discussions now and could look back and say we had a proper, honest kicking of the tires in that programme than we have a problem with it and wish later that we've been a bit tougher on one another. So I'd say kind but constructive challenge is what we need at the board table at the minute.
I would add to that that really plays to the role of the board committees as well, where there's even greater opportunity to delve into some of the detail, because the data that comes into those committee meetings through the reports
that's where some of that initial sight of that evidence is, really to explore and to question and to challenge, which I know committee members do, but it's a time when that's more important than ever, and an opportunity to work with some of the exec colleagues in those meetings and then bring that assurance into board. It's really helpful. Good. Thank you very much. On again with you, Matthew, verbal update on where we are with the acute provider collaborative.
I don't think there's much to update on. We had a good session with the boards and exec together in Whitechapel recently, and Jim Mackey spent an hour with us actually talking through some of his priorities, which was great and really insightful. I think the programme's focusing well on a couple of key clinical and non-clinical areas where we can deliver together. And I think we can probably come back to that in the autumn.
It certainly feels much more like a collaborative in a forward-looking way now, and three sort of equal partners thinking about how we can work better together, which I think is a real step forward in terms of the culture for the.
And just at Trust Exec this week, we had a presentation from the renal teams that are working across the three trusts actually, and the clinical lead from the Royal London Hospital came along with our renal clinical lead, and it was just really good to hear them talking about the way that they're working together to build the clinical network to try to deal with the increased demand for support for people with chronic kidney disease, acute kidney injury, etc. as well. So I think it's just to assure people that there's plenty of clinical and operational collaboration going on within the organisations, irrespective of the presence of the APC or not. You know, the clinical staff want to get on with working together, particularly in those areas where the population of total ignored people on the more benefit.
That's fabulous. That's a really good example. Thank you. Great. Okay, let's move on to the Quality and Assurance Committee report. Over to you, Hilary.
Thank you, Sarah. So first of all, start with the first item stating no assurance is not meant to set hairs running and make you think that we have fundamental concerns about the diabetes service, because that is not the case. It is more that what came to Quality Assurance Committee was not designed to give us assurance, if you like. It was in some ways the wrong paper to the wrong audience, as Ruth, I think, would attest. And so actually we will be coming back to that at a future, probably in March. And meanwhile, I think what you'll see from the narrative is it was a little bit too acute focused, and actually it's quite timely today with the 10-year plan that we need to be thinking much more holistically. There wasn't as much, you know, and even thinking in terms of actually when diabetic patients come to an acute organisation, it is either because they're antenatal or because they have a crisis that needs hospital intervention, and that actually the vast majority of diabetic patients could probably be managed, the vast majority of their care, in the community. So I think that's the reason it says no assurance. It's not a negative. There are no items for escalation to the board. I think, and thanks to Nick and others, I don't know if you noticed, but I felt that the minutes this time were actually more succinct and pithy and to the point. So thank you. I think the only other one I wanted to pick out, and it's not to delay things, was the duty of candour under item 3.1, where we have a figure of 40%, which is obviously well below the 100% target. I partly mentioned this because Leslie and I we had quite a Barts today, where we had quite a detailed breakdown, and what was really quite striking at Barts, and it will be in the public domain shortly, was the difference between the 4 hospital sites. And not surprisingly, St Barts had the 100% across the board, probably because it doesn't have the same demands as ED and midwifery, etc. But even Whitcross had made a huge effort and had some great progress, whereas Newham and the Royal London hadn't. So I just wonder if there's some cross learning that bring there to look at that perhaps in more detail at some future point. But I will hand over to Nick now, really, for the 2 other main aspects from a maternity perspective, which is obviously an area that we spend a lot of time talking about.
Thank you. I'm just going to be very brief summary.
Good afternoon, everybody. My name is Abby, and I'm going to be very brief. In terms of the maternity report, I believe we've all had a read about it. Just the key highlights there is just in terms of, just as it's just been said, in terms of the HCL related to the diabetes, but that has been discussed in various meetings on the steps we're going to take about that. And we're working on that just to ensure that we put things in place so that it doesn't impact on our CNST. The second thing is in terms of our in terms of our scorecard. Our scorecard that we do quarterly is in relation so that we're able to triangulate our analysis of claims, incident complaints, and associated learning alongside ongoing actions. That has been discussed in other meetings, including MAB, work as well into details. So those are the three highlights in this report. Any questions?
So thank you for the update. That's really helpful. And it's just from a positioning point of view, Nick, Andrew, and I had the chance to visit the Gardens of Peace a couple of weeks ago, or maybe it was even only last week. Just highlighted the importance of all the work we're doing in relation to our maternity services, because it's very visual there just to see those babies and early pregnancies that have been lost because everything is buried in the Gardens of Peace. But it's a visual reminder of just the important work we're doing in terms of our maternity services and how many people we care for. And so I really appreciate you bringing that update. Thank you very much. Really helpful. Thank you. Nick, should we move on to
the next one's a CQC.
yes.
Survey.
Okay, in terms of the CQC survey, I believe you've read that as well.
Yes.
And just as we've seen in the NHS plan and other media now publicity, is all about listening to the voices of the women. We put a lot of action plans in place. And the women that are going to be surveyed for this year are the women that are the women and Baton people that are delivered in the month of February. As a team, we've already marked and spoken to over 100 of those Baton people just to have a feel of any concerns that is being raised. So some of the things they fed back to us, we're working on it at the moment, and we've translated it against our action plan.
Thank you. Again, really helpful just to have that level of detail and hear that specific feedback. It's always really comforting to know that the work we're doing is in response to and is meeting the needs of the feedback we're getting from those people who've used our services. Thank you. Any other comments, questions?
I was going to make a comment on the earlier item, but then I sort of left it. But if I can just come back and do that, I mean, first of all, it's really good to have a couple of paragraphs in here and the analysis around deprivation and ethnicity and all of those other factors that drive poor health outcomes. So that's good to see that in a acute trust board paper, and encourage that to happen more often in our papers. It gives us a better understanding of our communities. And secondly, it's great work that's happening to reduce the disparities of stillbirths and outcomes, and that particular approach towards continuity of care, linguistic and culturally appropriate care as well is very welcome. So it's not a question really, it's a comment that we take back to the team.
Yeah, no, completely agree. It's a really good point. Thank you so much. Thanks. Thank you, Abby. So Nick, still with you on the integrated quality and safety report.
Yes, thank you, Chair. I think the paper is read. We're working really well with clinical teams around some improvements around quality and safety, and we've made significant progress. Just to call out a couple of the areas that we're working on is working with clinical teams about closing some of the open incidents. So we're working closely with teams on that. We had one liver event related to a medication incident, and we've had a good trust-wide response to this so that we can share learning. We're doing a deep dive into medicines administration and management and including that in our walkabouts. You see there's a decline in the report of pressure ulcers, and we believe that's related to we've got less duplication. We've found that we were duplicating some of our reporting as opposed to staff not reporting pressure ulcers, so that's good to uncover that. And also, despite the busyness of ED, we've seen an improvement actually in the friends and family feedback, which is really good. And I'll just take any questions.
Thank you. I mean, one of the things that it highlights, sorry, I come to you, as attention, there were the explanation given for some of the issues was reduced level of staffing. and some of the teams and so on. And when we're hearing about all the pressures and the cost saving, and one of the greatest ways of cost saving is headcount costs and so on, it's just a bit of a tension there. And I wonder how we're navigating that to maintain quality and safety levels we want, but working within our ambition to keep the costs as low as we can get them.
So I just wanted to come in. So in terms of the staffing, when we say that where we're not booking agency or bank staff, it's where previously if there was a shortfall, someone calling in sick or people being on leave. For most of our shifts, actually, we are at full establishment. So actually, we have more people, as Matthew mentioned, around the 400 more nurses. We have more people available to care for patients than we've ever really had before.
Thank you.
In terms of quality assurance, the ED, we look at all the great figures that are coming out, and we know that we're doing well in lots of different areas. And notwithstanding the work that Ruth and Fiona have done, which has made a great, we still have a lot of people who turn up with like abdominal pain and that. And if you turn up there at 8 o'clock at night, you will probably still be sitting there 8 o'clock the next morning in a chair waiting to see a clinician. And we mustn't lose sight that is really not good enough, and it's ongoing. So I'd just like to highlight that issue.
Absolutely, fair point.
Thank you.
Thank you, Ron. You. Fine. Okay, let's move on to Leslie, the People and Culture Committee.
Thank you. Just a few points to highlight. We've got freedom to speak up annual report on the agenda, but I just wanted to say a big thank you to Sue in her absence as the board champion, and to Paul for all his hard work, and really to highlight for me what I think is a really significant change, which shows the improved trust that our staff have in the service as a psychologically safe space to speak up, because only 1% of staff chose to withhold their name from the Guardian server, whereas in 21-22 that's 39%. That's a really marked reduction, and I think a real signal that with the service and the work that Janine's team have done, and Sue have done, and Paul have done in getting out and talking to staff and making staff feel that that's safe for them to raise issues. A couple of other issues to highlight. We had a good paper on developing our role as an anchor organisation, and talked about workforce and skill, community engagement and partnerships, procurement, spend, estates and infrastructure, and sustainability, and how we can work. And we're doing some really good things in some of that space that perhaps we don't hear as much about here as we should do. So I'll speak to Soph about at some point bringing a report that pulls together everything we're doing in terms of we had our usual med update, and in our round of people that come to report to us, geriatrics came, and we also look at the Guardian of safe working. And again, we've had a period of declining clinical supervisor engagement, but that's actually beginning to turn around. I think some really good work is happening there. And finally, just on the EDI update, where we had sort of almost a review of the work that we've done over the year. And I just here also want to pay tribute to the incredibly valuable contributions that are made by the staff networks and the chairs who turn up to PCC, but everybody involved in the networks, because they give us so much in terms of time, energy and support in developing a lot of what we do. And they've got some really ambitious plans for next year on reducing discriminatory behaviours and systemic bias, more inclusive culture, sustainable change, which I think is really important beyond some of the good initiatives that we've got, and creating that culture that values people for their strengths. We were talking about that earlier on, and their contributions, and making sure that everyone feels empowered and that their lived experience is of value to us. So it's going to be tricky to maintain momentum because they're very ambitious plans and we need a transformative approach. But I think the network have played a really important role in the work that we've carried out over the past year in terms of culture change and workforce development. So I just want to thank both of you said it at PCC to say a big thank you.
Excellent. Thank you very much. And it is good to see it. It's a dramatic step forward and pacey actually to drive that changing how it feels for people. It's not an easy achievement. Thank you very much. Now I'm very conscious that we were due to have Paul join us, but we're running a little bit ahead of schedule. Are we able to contact him and see if he's able to join in?
I have emailed him. I've emailed him to join it earlier.
Okay, brilliant. Would it help to give people just a quick 5-minute comfort break? 'Cause I'm conscious we haven't had one. Might give him a chance to join. Yes, indeed. Okay. Oh yes, we could always switch things around.
We'll keep it brief, and if Paul isn't able to join, we can switch things around. Oh, joy. Thank you very much. Brilliant.
Do remember we're on broadcasting, so your conversations will be held.
City is in.
Wonderful. They ballet was really.
Yeah, well, that's okay in a phonetic way. I've seen ribbons and all sorts. We love it. Okay, I think we're time to move on. Paul, thank you very much for joining us slightly early. Sorry to grab you sooner than you were ready, probably, but we were slightly ahead of schedule, so I thought we'd take advantage.
Yeah, no
So
problem.
our next item, which I think you're going in to introduce, we're going on to the Freedom to Speak Up annual report.
Yes, so it would have felt like yesterday that we had the mid-year report from Paul, but we are now here to hear from Paul the full year's data and giving an overview of the trust performance. I won't steal any of your thunder, Paul, in terms of the detail, but I do want to say a real note of thanks to Paul. The Guardian service, I think, has made a real difference to how it feels to staff to be able to speak up freely without any fear of repercussion. And we've seen, as Leslie mentioned, the percentage of people choosing to remain anonymous has fallen significantly. And I think that's a real testimony, Paul, to you and your hard work in making sure that people feel safe and they feel supported. They go back and they speak to their colleagues about the service, and we're really building a momentum. And Paul also makes himself available to attend our corporate welcomes and team inductions as well, so people know Paul and he's a visible presence whilst maintaining that sense of independence from the trust as well.
Brilliant. Thank you, Paul. Over to you.
Thank you. I'll take the report as read. The 12-month period between the 1st of April 2024 and the 30th of March 2025 saw 196 new concerns being raised. This is above average for similar sized trusts, but it's in line with our improved rate of concerns that we've seen at BHR in the last few years. That comparison is made per capita with other acute trusts as collated by the National Guardian Office. It's also worth noting that the Guardian Service and the National Guardian Office also report that concern numbers are increasing across the NHS year on year. With more focus and scrutiny in the media being placed on tragic cases and the performance of NHS services, this could be a contributing factor to why there's perhaps a greater awareness and motivation across the NHS to use the Freedom to Speak Up route. It should also be recognised that higher than average Freedom to Speak Up numbers show that the staff are aware of the Freedom to Speak Up route at BHRUT and are confident in using the Guardian service as an option to raise concerns. The confidentiality data, as Janine says, continues to show improved trust in the Guardian service as a psychologically safe route for speaking up, with only 1% choosing to withhold their name from the Guardian. There is a graph in the report which illustrates this significant improvement over the last few years, falling from 39% in 2021 down to a really negligible figure last year. Positive experiences, as Janine said, via word of mouth, spread the word, and bring more people to the Guardian service. It's not just the work that I do, of course. The majority of staff chose to speak up because they felt they were not being listened to, would not be listened to, or were fearful of potential detriments happening to them if they spoke up via other internal channels. The top 3 job groups raising concerns were nursing and midwifery, medical and dental, and admin and clerical. And the 3 most common themes for new cases were management issues, again at the top, with system and process, and bullying and harassment in 3rd. One of the most important factors contributing to a well-functioning speak-up culture is, as we've discussed previously, the speed and the quality of the responses to the concerns. And there have been some good examples since the beginning of the Speak Up year where the Trust have demonstrated they are listening by responding to concerns quickly and attempting to address them. This definitely contributes positively to staff having more belief and confidence in coming forward with their concerns and their ideas, of course, to make things better. However, it remains in some instances that staff do still report their frustrations regarding the quality and or the speed of the responses from the Trust. The Trust has progressed a great deal in this area, but there is still room for improvement. It must also be said that in some cases, the issues being raised are quite challenging to address quickly for a variety of different issues, including, of course, financial resources and restrictions that are there, and also other resources might be available or not to the Trust. But where necessary, the Guardian Service keeps listening, talking to appropriate people within the Trust to keep the focus in areas that appear to need more attention. And in practice, this can sometimes lead to smaller steps towards improvement rather than radical leaps, but it's still positive development nonetheless. The Guardian continues to meet monthly with the Chief People Officer, Head of EDI and Non-Exec Direct Lead for Freedom to Speak Up, where we discuss emerging themes, obstacles to improvement, progress and potential pathways to improvement. These discussions have contributed to a number of new initiatives and policy enhancements that have been developed over the last year that offer some evidence that the organisation is taking steps to demonstrate that the Trust is listening more to its staff. The launching of the Violence and Aggression Programme being quite a good example of this. And there are also a few more examples that you might have noticed at the back of the report. Does anyone have any comments or questions?
Yes, I think people do. I can see hands going up. So let me go round. Leslie first, then Marta, and then Ruth. Leslie.
And thank you, Paul. And I was saying before you arrived that we owe you a real set of gratitude for just your visible presence and the way in which the Guardian Service work, and had commented on that, you know, reduction from 39 to 1% is a testimony to the fact that people feel that you provide that psychologically safe space. So thank you for that. It was really a comment on one of the points Paul made about sometimes we are not as speedy in responding to issues, which can be a whole variety of reasons why that's the case, which is why we had the discussion which Sue raised earlier on, just to loop back to that at Audit Committee, about adding into the internal audit programme for this year a look at what happens to things when they arrive from the Guardian Service into us, and then how quickly do we close that loop. And I think having a little bit of an independent look at that from our internal audit colleagues will help us with some learning about what we might be able to do, notwithstanding what, you know, Paul has said, that some things do take a long time, or some things aren't within our, you know, we cannot redesign ED to make it an easier work environment for people at the moment because the layout is just wrong. So some things we can't, but we want to just see if there are any learning that we can do to improve that feedback.
That's really helpful. Thank you very much. Marta.
Thank you very much for the report. I just wanted to pick up two specific areas. You did mention, I was going to ask about it, the work that we did on the campaign about inappropriate behaviour. And the other area that I wanted to actually talk about a bit more is sexual harassment. I noticed within the report the information that you have commented on was anecdotal, so I'm not entirely sure if this is an area that you have information on, or if this is an area that is actually covered by our people services. But I was just actually wondering, in those two particular areas, have we seen, since we've launched campaigns, have we seen any response? Is it more about more people reporting to us on these activities so we can deal with them, or is it that we're seeing a reduction in the occurrence of these kinds of behaviours which are inappropriate?
In terms of the sexual harassment, it's a very difficult thing to address because, as I'm sure you're all aware, many people do tend to suffer in silence with it. There are a number of reasons for that, and as part of the campaign that I just mentioned, I'm doing a video that's going to be circulated around the Trust, linked to those themes, to try and encourage people to come and speak to me and have, you know, in that psychologically safe space, if they feel they need to. It is something that's typically underreported across the NHS, but I've heard that there are more people raising concerns recently as a result of others coming forward, a little bit like the Me Too environment from a few years ago. I think sometimes when you give confidence to people that they're going to be supported, there's going to be appropriate actions taken, then I think sometimes that naturally gives, more comfort and brings more people forward. But you've got to deal with those cases as they come forward, and sometimes that can develop a bit of a groundswell, so I anticipate possibly more things coming out over the next year as this subject gets a little bit more illumination within the trust.
Thank you.
Thank you. Ruth?
Mine was just a couple of notes. Just within the report, would you mind doing an additional graph that shows percentage? So obviously we know there's going to be more we'd expect there to be more at Queen's, but actually what proportion of staff therefore is that? Because do you see what I mean? The bar graph will obviously show more, but actually is it proportionally more here compared to King George, or is it actually just equal? And that's the same per speciality, because it can look like a speciality has got more, but again, proportionally, have they got more or not? Because I think that would let us highlight if there's a problem in certain areas more than others.
That's something I could possibly add to with help from Workforce. If they provide me with the data, then I'm sure I'll be able to work that out.
Thank you. Paul, thank you. It is really helpful to see a report in this way, and I think you kind of alluded to it. So it's the data we've got and what you might anticipate to follow is, I think, quite typical of the positive journey you're helping us go on in terms of having a strong speak up service that itself is then delivering a much more confident speak up culture. So to see it would be expected to see the increase, as you suggest, of more people feeling empowered and feeling that it's going to be worthwhile to speak up, and the fact that they choose to do so openly rather than anonymously is also a really positive sign. That said, I think apart from obviously the practicalities of responding positively and constructively to those who have spoken up, so they feel that action's been taken, even in the spirit of people speak up more because they feel safe to do so, nevertheless there's a message and there's some themed learning for us in terms of issues that are aired. So many of the comments that people have made, or the issues that have caused people to come through to you, are management related, and I think we need to make sure that we are absolutely sharing that learning in terms of those themes throughout the organisation, to try and continue the drive and the journey in terms of cultural change and behaviours and so on. And I think I don't know how broadly we share this information throughout the organisation, but somehow talking about the themes, both for staff generally to see that themes are noted and that what the trajectory is in terms of the positive where we've got to. But I think also it's a really important way for staff at all levels to get a sense of what we're aware of, what we're concerned about, what we all need to pay attention to, in terms of creating an environment that will hopefully mean fewer issues are raised because people are satisfied both with the support they're getting in their teams, but also feel perhaps more comfortable to raise issues through the routes we prefer them to, so they can be dealt with in the moment. It's just a bit of learning, but I haven't, obviously this is my first time seeing annual reports, so I don't know what the norm is for how we disseminate this kind of information throughout the organisation.
I mean, just to say, I mean, Paul has spoken to members of the Shadow Exec over the last couple of years, which has been really good. And interestingly, despite the increased response rate, which I think shows good awareness of the Guardian, every year we hear comments from some of the Shadow Execs saying we could do more to promote the existence of the Guardian as well, and there's always real support for that and real interest in it. Because I think to Ruth's point about looking for service, I'm more worried about places where there's zero reported. I think that looks odd. You know, take some comfort from seeing a service that's got a couple of dozen reports, because knowing the size of some, if you've got 1,000 staff, you'd expect there to be some issues at work actually. And I think some of the areas where you see very low levels of reporting, we do encourage as a thing perhaps to make sure that we do a bit of targeted work there as well. But we do try and share it. We take it to Trust Exec Committee as well, and I think we do make sure that the report, as you can see here, goes into public board papers in as full form as possible as well. So I think we're very much working constructively with Paul and the Guardian Service to make sure people are aware of its fact.
And Paul, thank you. It's a really rich source of data, and having the ability to interrogate it. I mean, the analysis you've given, but then I'm sure for Janine and team, really helpful to guide where we want to focus our efforts and attention in terms of management, training, support, communication, all of those things. So really valuable. Any more questions or comments for Paul before we let him go? No, Paul, thank you. Really appreciate you joining us early, and really appreciate the content of your report and your presentation. So thank you.
Thank you.
Brilliant.
Bye, everyone.
Right, we're on to the performance report. Max.
Thank you very much. So again, I'll take the report as read. There's a lot of numbers through there, and some of those headline numbers have been picked up by other speakers today as well. Start off very briefly, just an overview of UEC. So real continued strong performance of the all-time performance for the A&E targets, and that's despite the increasingly busy months that we've had, May being our busiest May so far, and we've recently had the busiest June that we've had. So it's really good to see that we're still holding place as third in London for UEC performance overall. Some concern obviously around type 1 performance being lower than we had this time last year, but that is against sort of increased demand we've had through ambulance conveyances. So it's sort of, you can sort of see how those two things play together, but it is going to be something we're going to need to focus on, I think, over the next few months. But we are ahead of our recovery trajectory and are still supported by really strong type 2, type 3 performance. Mental health patients challenge has already been picked up in previous report, and we are going to continue to work with NELFT on how best we interact with the new capacity that's been made available at the Goodmayes site for their crisis assessment centre. In terms of improvement work in general, we have got the first week of recording of the frailty line, which means we can now use it as a single point of access for our LTV population, and hopefully can start looking at those routes through to St George's Ageing Well Centre that we've talked about already today. We are in the moment working through some bed modelling work for all of the clinical groups, and looking at whether we've got the optimal configuration of the beds that we've got to try and improve some flow out to ED, as well as a revised model of how we provide sort of the responsibility of the various teams as a patient moves through the journey from the front door into a bed. And this piece of work that we're doing alongside Andrew, just looking at how the medical model of that fits together. So real focus on trying to improve flow, because this is the time to do that before the winter pressures hit. We've also got an annual goal around how we work with base partners, integrated neighbourhoods now, on providing the right care for the right patients in the right place. And so we'll be thinking a bit about that as part of our improvement strategy over the next few months as well in the UEC space. On the planned care side, so we've had incomplete performance of 70.6%, so we're just a bit behind our operating plan trajectory overall. And in fact, we're at 1.1% of our PTL being at 52 weeks or above, which is slightly above where we're supposed to be by the end of the year. There are some particular challenges. Gynae, we've talked about a lot in this environment before and in various other forums as well, although it is an improving position, but we do know there is a challenge around particularly demand and capacity in that area. We've also seen some challenges in ENT and general surgery, and there is some work across North East London to think about how those services are best provided and what kind of community provision will help to offset some of the demand we've got in acute care. DMO1, we've achieved again now 12 months in a row, and we've had really good improvements in MRI, particularly in the paediatrics and general patients in general anaesthetic MRI scans. But we've got, as you'll see from the DMO1 chart, problems still in sleep and neurology. We have now got new technology coming into sleep as of this week, which should mean that we can increase the capacity that we've got for sleep studies. So we should see an improvement trajectory for that over the next few months. So I'm quite enthusiastic about that. And we are looking, as part of our outpatient transformation plan, specifically looking at one-stop clinics in neurology to try and bring those diagnostics onto the same day as the first appointment, and thus reduce the challenge that we've got with both urodynamics and cystoscopy in neurology. And then for cancer, we are ahead of our operating plan strategies that we submitted at the beginning of the year. There does need to still be a focus on the 104-day backlog and the 62-day backlog, which are both higher than we would have anticipated. The pack on the last page has got sort of a summary of where we are against our trajectories, and we didn't have the validated May position for that table, but I can confirm that all three of the standards, 28 days, 31 days and 62 days, are all now ahead of where we expected them to be. So really good news on the cancer side. There's specialties of interest that we're still looking at: the skin pathway, urology and gynecology as well. We are undertaking a series of deep dive reviews with the operational and clinical teams in sort of two separate forums. So we've got a set of deep dives with the service management and operational management team, looking at patient pathways and how they're hitting particular time scales in the time pathways that are being developed across North East London, and trying to identify those delays and working through how we can change processes to improve performance, which I think has been really well received by the operational teams. It gives them a bit of additional support. We've now got a full complement of quarterly quality meetings with the clinical teams, which obviously the operational teams attend as well, where we're going through both some of the quality aspects of how pathways put together, patient experience, the holistic needs, and the COSD data, all of which will give a bit of a picture about how patients experience our services. And that's given us a sort of bit of focus time with myself chairing with the tumour group leads to actually talk through issues they've got with the clinical delivery of their cancer care. So I think we've got really good structure now how we're going to make those improvements, and I'm hoping that's going to bear fruit in the next few months. And then finally, just a bit around outpatient transformation in general, which we know is sort of underpins all of these three areas. EPR is providing us an opportunity, a bit like the pandemic did, I think, for virtual working, to have a look at some of the real basics of how outpatient care is delivered at BHIET. We are doing a very in-depth review of what clinics have been built on the system, like sort of minutiae of detail, and it's sort of giving us a bit of an idea about use follow-up ratios, how much we're using PIFU, what we're using telemedicine for, and how we might be able to use it better in the future. So it's sort of been good to go through the EPR program as a sort of exercise of talking to the operational teams and the clinical teams about how they deliver care. So although it will take us a little while to try and make some of those transformations, it's given us definitely some identify some opportunities, I think, in how certain services are delivered. And then a wider sort of transformation program we're looking at, which includes the one-stop clinics I've already mentioned, and straight to test pathways in a certain number of specialties, including respiratory. That has been coordinated across North East London. So we're very linked in with our other provider colleagues in the sector, which is good, as well as being part of the overarching London Learning and Improvement Network for outpatients, which we're really vocal contributors to, I would say, in a constructive way. I don't mean to make it sound shouting at everybody. So that's a sort of a summary of performance and some of the improvement that's going on.
Thank you, and really helpful. It's a really positive picture of a huge amount of work being done, but a really good mix, it feels, of tackling the day-to-day and keeping an eye on and moving in the right direction, all of those metrics, and at the same time, the partnership working, the engagement with NELF, the other areas of improvement, and looking at where we can make more positive progress in addition to those core metrics. So really, really good to see all of that. Any comments or any questions from around? Yes.
Quick comment. Thank you very much, Max, for stepping in. Excellent update to the board. Can I ask around theatre utilisation and efficiency? Because there are 4 specialities that fell below the 79% target. 81% are overall, and we're really stretched to get to 85% this year. And it's slightly worrying that gynecology and urology are 2 of those that fell below that, and that doesn't align with our ambitions as an organisation for those people who really desperately need those services. I didn't mean to put you on the spot on that, so there you go. But if there's anything that you could give us in terms of assurance to the board here, and passing a message to Fiona, saying perhaps we could get a more of a deep dive on those at the next FIC, please.
Yeah, definitely. So we're picking up these areas of poor performance and data utilisation at the Planned Care Board, and then we're asking for specific recovery plans, meeting the specialists that fall behind the target. One of the things that I think we could do in the theatre space here is a bit more of a strategic improvement conversation about the flow through theatres and how we develop innovative ways of managing patients on that pathway. We don't have a trust-wide meeting that looks at that, but I think it's something that we should be developing to try and have a look at how do you minimise the time between patients, the turnaround time, how do you think of the workforce in a way to try and improve that. But we will have individual trajectories coming back from those specialties, and I can get a coordinated report for the next one of these meetings.
I really like that idea. I just want to share with the strategic approach across the organisation where we can learn from.
Certainly,
Yeah.
really helpful.
Thank you.
Thank you very much. Thank you, Max. A really good update. Thank you, and for stepping in. Thank you very much. So that brings us to any other business. I have one item. Does anyone else want to raise anything under AOB? So mine is to say a huge thank you to Ron, because I think this might be your final board meeting with us. So I just want to say a huge thank you. I've only experienced your contribution for a short number of months, but I know many people here have known your contribution and your involvement for a much longer period than that. You've been a huge support to the trust in terms of your representation and voice, representing patients' interests, needs, views, concerns, and all of those things, and a really helpful challenge and input around the board table. So just want to mark how much you've done for the trust and to say a really big thank you, and maybe we could give a round of applause to
You embarrassed me, Sam. I'm not disappearing altogether. I'm relinquishing my role as the
indeed
patient partner chair, patient partner council chair, and I'll still be doing other bits, particularly my safety roles that I undertake. So you will still see my face around the trust. But I'll be handing over to Stephen, take on that role, and you'll see his smiling face.
Indeed, and thank you,
Thank you very
for
much.
stepping up. I hope we haven't put you off. At least you've had a chance to see what you're letting yourself in for. Thank you. No, hugely appreciated that there has been a huge amount of input and a lot of time commitment as well. So, as ever, I did. Was your hand up, Mark? Sorry. I thought yes, it was applauding as well, but hand up.
No,
So sorry. Thank you.
I was up, Sarah. Sorry, I'm not with you this afternoon. We hosted the Prime Minister, Secretary of State, and the Chancellor for the launch of the NHS plan at the Gutman Centre this morning. And I can't tell you, when we came in last night, how much chaos it caused. But anyway, it went off okay. But actually, what I wanted to say was just earlier in the patient story, there were some matters that we weren't able to hear about or address, and I just wondered if we might ask Andrew to look at the matters raised. Just particularly, I mean, I think there were many positives there, but there were also some issues around things like pain control and potentially lessons learned about waiting in the right space. So my question is, have we learned those lessons? And it would be good to just have assurance that we had. Sorry.
I'd noted down to check my mistake.
Thank you. I thought you might have. I just wanted to say.
Yes, no, we did discuss it. You possibly had stepped out by that point, but certainly between Max, Nick and Andrew, we said we would make sure that things have either already been addressed or anything that was new learning from today has been captured and will be checked so that we make sure we do learn. Because some of, I think Gulshan had already given some of her feedback earlier, so some of it has possibly been attended to already. Thank you, good point. And I hope it was an exciting morning. Right, so any issues around meeting effectiveness, please do let me know if you don't want to raise anything now. And otherwise, I will open us up for any questions from the public. Oh, yes.
Thank you. Thank you.
Go ahead.
Thank you. Firstly, I did put something on Twitter as a question, but so I seek your permission to delete the first question. I was particularly interested, if it's helpful to you, about Mr. Wright's comment earlier that if he was in A&E at 8 o'clock in the evening, I paraphrase the exact words, but it was something like there's a real prospect 12 hours later
that you wouldn't have been seen by a clinician. Now that interests me because there is statistics.
Okay, Andy, let me just clarify that.
Okay.
You would have been seen by a clinician. You might not have been seen by the specialist that you need to be seen by. So you might not have seen the consultant or a doctor from the medical team that actually needs to see you. If you come in at 8 o'clock at night and you're having a heart attack, you will be seen at 8 o'clock. And I speak from the same perspective as you, really. I am a member of the public, I'm a patient, and I'm a patient representative here. You probably don't realise that I'm actually not one of the employees of the trust. I'm a patient representative, that's my role. So I'm speaking from almost an educated point of view, and it is my position to highlight problems where we see them. And I do know that if you come in with something that's not life-threatening, and this trust is very, very good at treating things that are life-threatening. If you come in with something that isn't life-threatening, like abdominal pain, you will be seen by a clinician, but it might not be the specialist that you actually want to be seen by or need to be seen. But you would have been seen, you would have seen a clinician of some sort, you would have been assessed, and they would have done an assessment that says that you are not in immediate danger, and therefore you can wait a little bit longer to see the specialist you need to see. Is that fair, Nick?
Yes, that's absolutely fair.
Okay, that's answered my point, Chair. May I ask a second question?
You may.
I'm focusing on an Office for National Statistics survey, which claims that 12-hour waits are associated with higher death rates. As a layperson, I was surprised. I thought it was merely elderly people who are at risk from 12-hour rates predominantly. But according to the ONS, it's younger people too, which is of concern to me. The Trust looked into 12-hour rates, I think it was less than 12 months ago. But from memory, the sample was for elderly patients rather than across the range. Any comments? Does a clinician accept what the ONS is saying, or is the ONS out of step?
I think Matthew was going to come in on that.
Yeah, I'm not going to second guess the ONS on that, and I'm sure their evidence is solid around that. We know 12-hour longer waits are generally associated with poorer outcomes. The majority of our 12-hour waits for younger people are related to mental health services. And so as a result, when we looked last year at the harm attributed to the long waits in the emergency department, we did concentrate on the elderly patients because that tends to be where we've seen the greatest risk of harm. But it's a good question, actually, Andy. So the younger patients tend to not be under us for medical care. They tend to be waiting for a referral onto a mental health service. But we can have a look into the numbers for you on that. And maybe I don't know if a written response is the best way to follow that up, but it's a good point. It's not an area I've been particularly cognizant of until now.
Okay, thank you for the reply.
Thank you. Excellent. Well, if there are no other questions, let me say thank you to everyone for attending our board meeting today. Our next board meeting will be on Thursday, the 4th of September. And the timings, I think, might be adjusted slightly so that we can accommodate our AGM on the same date. So we will advise of the start times, but the public meeting may start slightly earlier so that we can have the AGM at the end of the afternoon as well, whilst people are here. So thank you very much for that, and thank you for attending. Thank you. Thanks to those online.